Welcome to this session on acute inflammation. In this lecture, we will explore the mechanisms, vascular and cellular events involved in the inflammatory response. As nurses and healthcare professionals, understanding acute inflammation is essential because it forms the foundation of many clinical conditions we manage daily. What is acute inflammation? Acute inflammation is a rapid and protective host response to injury, infection, or tissue damage. Its primary objective is to eliminate the cause of cell injury, remove necrotic tissue, and initiate repair. The classic cardinal signs of inflammation are 1. Redness 2, heat 3, swelling 4, pain 5, loss of function. These signs reflect the underlying physiological changes in the affected tissues. Remember, inflammation is not harmful by itself. It is the body's essential healing mechanism. The first major response in acute inflammation involves vascular changes. 3 key processes occur. First, vasodilation increases blood flow to the site of injury. This explains the redness and heat we observe clinically. Second, increased vascular permeability allows plasma proteins and inflammatory cells to escape into tissues, resulting in swelling or edema. Third, stasis occurs as blood flow slows, enabling leukocytes to move to the periphery of blood vessels and prepare for migration. Increased permeability of blood vessels is a crucial event that enables immune cells and proteins to leave circulation. There are several mechanisms. Endothelial cell contraction, especially in venules, occurs immediately after injury and is mediated by histamine and bradykinin. Endothelial retraction, which is delayed for several hours, is driven by cytokines like interleukin-1 and tumor necrosis factor. Direct injury, such as burns or trauma, damages blood vessels instantly and leads to prolonged leakage. Leukocyte-mediated endothelial injury arises during severe inflammation and infection. Finally, new blood vessels formed in healing are inherently leaky due to immature junctions. These processes collectively allow exudation, the hallmark of acute inflammation. In addition to vascular changes, acute inflammation requires the rapid recruitment of leukocytes. The 2 major components of cellular events are 1. Exudation and migration of leukocytes, primarily neutrophils, to the injury site. 2. Phagocytosis, where pathogens and debris are ingested and destroyed. Neutrophils dominate in the early hours, while macrophages arrive later to orchestrate tissue repair. These coordinated events ensure efficient host defense. Leukocyte recruitment occurs in a stepwise manner. Margination begins as blood flow slows and cells move toward the vessel wall. This is followed by rolling, mediated by weak interactions through selectins. Next, firm adhesion occurs, primarily via integrins binding to ICAM1, intercellular adhesion molecule 1, and VCAM1, vascular cell adhesion molecule 1, on endothelial cells. The leukocytes then undergo diapedesis, squeezing between endothelial cells into the interstitial tissue. Finally, they migrate toward the site of injury by following chemical cues. This highly regulated process ensures that leukocytes reach exactly where they are needed. Once leukocytes exit the bloodstream, they are guided toward the inflammatory focus by chemotaxis. This movement occurs along a chemical concentration gradient. Major chemotactic agents include complement fragment C5a, leukotriene B4, interleukin-8, and bacterial products such as 4-methionine peptides. You can think of chemotactic mediators as a GPS navigation system that directs neutrophils to the battlefield of infection. When leukocytes reach the site of inflammation, they begin phagocytosis, a 3-step process. Recognition and attachment are enhanced by opsonins, such as I, G, G, and C, 3b, complement component 3b, which label microbes for destruction. In the engulfment phase, the microbe is internalized into a phagosome. This then fuses with lysosomes to form a phagolysosome, where killing and digestion occur. This efficient system ensures that pathogens and damaged cells are cleared rapidly. Inside the phagolysosome, microbes are destroyed through oxidative and non-oxidative mechanisms. The oxidative pathway involves a respiratory burst, driven by NADPH, nicotinamide adenine dinucleotide phosphate, oxidase, producing superoxide anion and hydrogen peroxide. In neutrophils, myeloperoxidase, or MPO, converts hydrogen peroxide into hypochlorous acid, which is the most potent bactericidal agent. The MPO-independent route creates hydroxyl radicals, which are highly destructive. Non-oxidative killing relies on lysosomal enzymes, defensins, and other antimicrobial peptides. Additionally, nitric oxide, generated especially by macrophages, has strong microbicidal activity. These mechanisms ensure rapid pathogen elimination and infection control. In severe inflammation, if microorganisms are too large or numerous to be phagocytosed, leukocytes release toxic substances extracellularly. This includes degranulation, where lysosomal enzymes and reactive oxygen species are released outside the cell. While this mechanism helps destroy pathogens, it can also cause collateral tissue damage, contributing to the symptoms and complications of inflammation. Thus, inflammation is a double-edged sword, protective, yet potentially harmful if excessive or uncontrolled. To summarize, acute inflammation is a complex but highly coordinated defense mechanism involving vascular responses, leukocyte recruitment, and powerful killing strategies to eliminate threats and initiate healing. A solid understanding of these processes allows us to better manage inflammatory conditions and support patient recovery. Thank you for watching, and don't forget to like, share, and subscribe for more evidence-based nursing education.